Hello, good morning, everyone. We're going to get started here. Thanks for coming. My name is Hannah Zaitlin. Our panel is called Building Brighter Futures. We're going to be talking about youth mental health and some of the kind of nuts and bolts and operational and legal considerations. If you've been to any number of panels over the last couple of days, you've heard, I'm sure, astounding statistics and stories about the prevalence of mental health needs for kids, teens, young adults, and the importance of finding the right solutions and interventions to address those needs. As I said, we're going to really break it down to the nuts and bolts today and talk about some of the legal and operational considerations. We have an esteemed group of panelists who are operators, clinicians, and legal experts in this space. Just a couple housekeeping items I'm sure you've all heard before we jump in. If we're happy to take Q&A at the end of the session. Save some time for that. You can provide questions via scanning the QR code or going to slido.com, or welcome to take questions up here. Just a bit of intro about myself. Again, my name is Hannah Zaitlin. I'm a healthcare transactional and M&A attorney at Foley & Lardner. We're a national full-service law firm. I work with a lot of clients in the behavioral health and SUD space on transactional and regulatory matters, both on the brick and mortar side as well as digital. So I'm going to turn it over to our panelists to introduce themselves, tell us about their organizations, and just start off by sharing what they see as some of the most notable benefits to providing mental health services to youth via digital health.
Hi, everyone, and thanks for being here this morning on the last day of this conference. I don't know if you're all as exhausted as I am from this inflow, the fire hose, but it's been so incredible. So I'm Kim Newell-Green. I am a pediatrician by training, and I always say I'm a mental health expert by the seat of my pants, because in primary care pediatrics these days, enormous numbers of kids and more over time come in to get their mental health care, and we all have to teach ourselves how to be mental health clinicians and give that kind of support. And I also have the challenge and privilege of having a 14-year-old in my house who has significant mental health challenges, and I've learned so much from trying to navigate their journey and figure out how to get support for them. So it is because of that I became the chief medical officer and co-founder of a company called Flourish Labs, and we recruit and train young people aged 18 to 35 to be certified peer supporters, so with lived experience, who are then supporting young people from 12 to 30, so adolescents and young adults, on their journey along the way to find their own recovery. And I know that we don't, in our pediatric offices and many of the mental health provider offices, have enough time. There aren't enough providers. And so I'll say, first of all, one of the most important benefits of building innovative technology solutions is just that we can bring support to the many kids who need it, and we can do it in innovative ways. And so doing it by telehealth and online can bring support to the areas where they're resource deserts, rural areas where they may not receive care, even urban areas where there just aren't enough providers. The other thing that we did when we first started this platform, well, first of all, I'll say, who went to see Lisa DeMore talk today? I'm such a fangirl, and so if I could stop talking right now and say what she said, I would. But she's powerful and has so much wisdom in this space. And she said a lot of what I'm going to say, because we asked the kids to, my daughter, and we did co-design sessions when we started this project, and we said, what do you want? How do you want to get mental health care? Because we're hearing young people don't want it in the way that it's been delivered traditionally. And a lot of things that we heard are things that we can provide using telehealth care and digital solutions in a way we couldn't otherwise. So young people want immediate care. They want it right now when they're feeling these big feelings. They want support right then, and we can't do that in the traditional healthcare system. They want to receive care where they are. They want it in their schools, in their homes, and they want it on devices because that's where they are a lot of the time, so a digital solution works for them. And they told us that they want to get mental health care, and they said this. They said, no offense, but I don't want mental health care from someone like you. I want mental health care from someone who gets me, who looks like me, who has had my experiences, and that's really important to young people. I think it's probably important to all of us. And so those are some of the benefits that we see and why we're trying to bring this solution into broader access for young people.
I am Carrie Wood. I am Senior Associate General Counsel of Regulatory and Risk at Spring Health. So regulatory and risk, yep, that's why I'm here. We're going to talk about all the legal challenges, which there are many when it comes to forming solutions for this population. And so Spring Health is a global comprehensive mental health solution. Our mission is to break barriers to access to care. And building off what Kim said, when I think about the benefits of digital health, telemedicine, where we are today, we are able to break those geographic barriers because we have providers and coaches and others who can reach these kids exactly where they are, even if it is in that rural or underserved population. One thing that I will say, I'll throw a little Go Spring in there, but I asked last night one of my team members back in New York, I said, hey, can you just tell me really quickly how many appointments with providers have we had at Spring this year? For minors. And so our under 18 this year, just therapy appointments. This isn't counting all of the other services that we offer that aren't clinical services. We've had over 100,000 appointments this year to date. And so there really is that need. And so I think that, being able to offer these services via telehealth and digital care is like really amazing and incredibly important because we are able to get in early. I was talking to some of the others on the panel this morning about how, when I don't think I'm old, but when I was a teenager, we didn't have social media. But I still remember middle school was horrible. There was so much drama. There was so much, just crazy stuff going on. And mental health wasn't something that we talked about. It wasn't something that, was addressed. And so I think, with all of these different services that we can offer today, from the subclinical to the, gaming apps, to the actual clinical therapy, we are able to provide that access and kind of break that stigma early, and I think that is the biggest benefit.
Hi, everyone. I'm Claire Marblestone. I'm a healthcare partner at Foley & Lardner along with Hannah. I am in the Los Angeles office, and my practice focuses on regulatory compliance and transactional work. A lot of my work has actually been in the hospital health system space. And so for me, one of the interesting opportunities of the innovative technology services that are available to young people is the idea that early intervention can prevent later institutionalization of care. I know we've heard a little bit about that today, and of course there's instances where that's very much needed. But one of the most inspiring things about working with clients such as yourselves in this space is the ability to kind of change that trajectory, especially for young people. And so, we're going to talk a little bit about the regulatory challenges and issues that you all face in, setting up these types of services and operationalizing them across many states. But I think that's the most inspiring thing to me, is that you'd be able to actually effectuate change with the younger population to avoid more serious levels of care later on in their lives.
Great. Thanks, everyone. So we've heard about the amazing benefits, very inspiring. Can we, the flip side of that, can you just talk about some of the challenges at a high level?
I'll go ahead and start, and we can switch it up other times. But I said a minute ago that young people want care now and immediately, and that's also a challenge, even in digital mental health, because we can build the tools that can help them do that, but it's hard to get reimbursement for that. So what we really need is to find new ways of getting reimbursement for the kinds of support that really helps young people. One example of that is that young people really love chat services where they can just go in and get chat right now. And Lisa Demore, I keep referring to her, said this morning that she delivers her support in 3 different ways, by a bite, a snack, and a meal. And I think that's really relevant to how young people want their care. Sometimes they just want a quick in and out. They want to share something and vent and get it off their shoulders. And they feel like, they tell us, a weight has been lifted from my shoulders. Other times they want a snack. They want a few chats back and forth, a message back and forth about a specific thing to try to problem solve. And then other times they want to come and they want to have a video visit where they really connect with a human. They can see them. It would be great if we could do that in person too, because that mixing of real human connection we believe is vitally important. But on our platform, they can have longer visits where they really work through a problem. The peer supporter brings out their strengths and says, how can you have everything you need inside of you to recover. How can we figure out how to take those strengths, build some goals, and then we'll work together. I'll work alongside you to use my own lived experience to help you do that. So that notion of the sort of bite snack meal really correlates with how I think the best way we deliver care to young people is. But that's hard to do, again, in the current reimbursement environment. The other thing is that young people really want autonomy, and often that means anonymity and not involving parents and caregivers in their support. And so there are lots of challenges that brings, both on the reimbursement side and also on sort of compliance side. But also, as a pediatrician, I deeply believe that behind every adolescent's mental health problem is a family that needs support. And then finally, the thing that I always say about young people is that they're admin challenged. So they often, not partly developmentally, but not only on their own fault, they might not have an ID. So how do you make sure the young person on your platform is who they say they are? They don't have any money, so they can't pay for the support if they want to come in and try it out before they get their parents involved. And they don't like paperwork and barriers. They just, again, they want to look at Instagram, get their support, and then go out again. And so how do we put in the safety? How do we let them know about some of the legal and compliance things that they need to know before they get true healthcare support? So those are some of the many things.
I think when I think about challenges, I think the first thing that comes to mind is something we've already discussed, which is the how. Figuring out the how. When you're thinking about building out a behavioral health solution for this population, how are you going to do it? How are you going to meet the kids where they are? How are you going to provide the services like Kim was just talking about that those individuals need? Again, gamification apps, coaching, peer support, actual clinical therapy. There's so many different facets of care for this population, and so it's figuring out how to best reach the kids where they are. And then once you do that, it's the bigger how, the part where I get really involved, and it's the how do we do this legally? How do we comply with all of the many laws across all of the many jurisdictions? Because every state has a different law about every different aspect of care. And so it's really just digging in and trying to figure that out, and it is not easy.
So building off that, not to be the downer in the room, but it is true that the law, and not to offend any payers in the room, but payers are a little slow to keep up with the fast pace that providers want to deliver care, that technology wants to be able to facilitate that care. And I think the broad issue that I see is founders or providers are coming to us with these amazing ideas and innovative solutions to care delivery. And just due to the 50-state patchwork of laws that we have, the many different ways that payers administer their programs, depending on which program they're administering in the various states, there can be some legal barriers to implementing the service in the way that you want it to be implemented. And a lot of times we counsel clients on just the risk that you're willing to take, because sometimes you have a mission and you want to be able to deliver care in this innovative way, and you'll figure out some of the risks later. So we do a lot of counseling about that because, like I said, the law is kind of slow to catch up with where the pace of healthcare is going and where it probably needs to be going. And we hope that the law and payers will eventually catch up and start to pay for and allow for providers to deliver care in this new and innovative way, because it has so many benefits.
So you all talked and touched upon some legal barriers or issues that are barriers to providing the types of services that you want to or you feel your clients need. Can you talk about those issues a little more specifically and things you've done to address them?
I'm happy to start. There are several, but I think just to kind of pinpoint the ones that I see as most relevant in this space is first is the prohibition on corporate practice of medicine. and various iterations of that in certain states. I come from California. We have a prohibition on many different types of clinical practices, licensed marriage, family counseling, social work. And so figuring out the type of care model delivery that you want to have, which clinician needs to be leading that type of service, what states you want to be in, whether there is an actually enforced prohibition on corporate practice of medicine that you need to kind of address from a structural perspective, and then figuring out which states you want to go into after your initial launch and whether you need to kind of retool or think about that end structure when you're setting up your first structure. The prohibition on corporate practice medicine has been around since the 1800s. It's not necessarily new, but there are some legal challenges that keep coming up with respect to corporate practice that we're kind of trying to navigate, and those keep coming up in different states, so we have to stay on top of those. And I mean, I'm sure you all can speak to some of the operational challenges, but even assuming you set up a friendly physician ownership structure or a PCMSO structure, it's not like managing a multi-entity operation is easy. There's certainly ways you can do it, but figuring out what's a clinical decision that needs to be made by the professional corporation, what is a business decision that the manager can be assisting the provider with, making sure that you're not overreaching in any of those lines. Those are kind of the longer term compliance goals. But so setting up the structure is something that we advise clients on with respect to corporate practice medicine often. I think the other issue that I see sometimes or that comes up occasionally in the behavioral health space, especially when you're dealing with a range of different types of providers, like peer support providers, full physicians, like therapists, depending on where you are, and again, depending on where you are in the country, there may be different legal obligations with respect to what you're hearing from patients and when you're hearing it and whether you have the appropriate context, whether that triggers a duty to notify identifiable individuals of, say, a patient expresses that they intend to harm themselves or others, what your legal obligation is. Did that arise in a peer support context where the person isn't a mandated reporter or has that licensing obligation to notify others? Do you have the right protocols in place so that you're not dealing with this on an emergency basis where the clinician comes to management and says, oh my gosh, this just happened. Who do I need to notify? Do we have their information? So again, when taking a step back at the planning phase, who's going to be rendering care? What are their obligations in the state? Can we craft the right policies to have in place so that when this happens, not if it happens, because in this space it will inevitably happen, that your teams have the policies and protocols in place that they need to provide the care and comply with their legal obligations in a way that works for everybody. So there are others. I'm sure we'll touch on them later, but those are kind of the primary ones.
I have many other. Kind of building off what you just said, talking about the mandated reporters, duty to warn, duty to protect. That is one aspect, but before you even get there, you have to figure out how you can see these kids, and so consent. Like, who has had issues with consent in what you do every day? Hands. It is so difficult. Every state has a different law around consent. And so, like, just for example, in Illinois, a 12-year-old can consent to outpatient behavioral health treatment, but that consent is limited to 8 90-minute sessions with a counselor. So after that, how do you consent? How do you continue to, see that child? In Oregon, a 14-year-old can consent to treatment, which is great, but they don't technically own the confidentiality of their records because the provider gets to choose when to involve the parent, and it could be on day one. And so with consent, you have consent to treatment, you have consent to records and confidentiality, you have to look at what that consent actually allows, how many services, what types of services. And then you also have to think about consent for financial obligations. And so, if a minor is consenting to treatment on their own behalf, are they consenting to pay for that treatment? Many state laws say yes, they're financially responsible for that. So then you have to figure out, okay, well, can we bill this to the parent's insurance? And so there are just so many facets of consent that make this exhausting even talking about it today, especially if you're in all 50 states. And that's just like U.S. We're not even talking international yet. And so consent is a big deal. And it is tricky and it is confusing. But another legal challenge, I think, is COPPA, the Children's Online Privacy Protection Act. And so, interestingly, just talking about how many different laws apply and how you have to think about all of the different components and aspects of what you're doing to see what laws you need to make sure you're compliant with. I was talking with someone here this week, and they were like, "What is COPPA?" Oh, I think that's something we probably should be doing. Yeah. And it's a privacy notice that you have to provide to parents for children under 13 if you're collecting any type of information about them online. And so when you're providing mental health care, you're collecting information, and so you have to make sure you're providing that notice, and not only providing the notices that are required by COPPA, but you also have to make sure you're able to operationalize. And so, the parent has a right to review the information that you're collecting. The parent has a right to request that you delete the information that you've collected. And so it's one thing to be able to have like a notice on your website or your platform, but it's a whole other thing to make sure that you're meeting those requirements and timeframes for actually operationalizing. And so, COPPA applies to children under 13, and then, look at young adults who are in college. You have FERPA, the Family Educational Rights and Privacy Act, I think. Yeah, okay. FERPA. And so FERPA applies to college students. And so, educational, you're thinking, okay, well, this is healthcare, it's not educational. But if you're providing mental health services through any type of university platform, through the Student Services Center, through the University Health Center, FERPA applies. And so you have to make sure you're enacting that and making sure you're compliant with that. And so, again.
And these are also different from HIPAA, not
right,
to throw more
HIPAA.
acronyms at everybody, but HIPAA is like the minimum baseline that applies nationally, but then you have to say, do you have to deal with FERPA? Do you have to deal with COPPA? Do you have to deal with a state version of HIPAA, which also can be different? So
You're totally right. And actually, that was one of my little notes that I put on my paper that I skipped over it. I missed it. Is that, some of the legal challenges that we're talking about are things that apply specifically to this population, but that doesn't even count all of those legal challenges that apply just to everybody else in providing health care generally. And so HIPAA, ACA, ERISA, if you're in that space, if we want to talk about law acronyms, we can go all day.
that was my joke. A lot of acronyms.
Even hearing this makes my stomach hurt, because as a healthcare provider, my one goal is to go and treat young people in the right way. And yet, as a leader of this company, as the owner of our PCs, I have to also make sure that I'm following all these regulatory and compliance things. And when the lawyers have to consult other lawyers who consult other lawyers in order to understand each of these laws and regulations, then a simple owner of a structure who really wants to do the best for their patients, it's kind of mind-blowing. So these things keep me up at night, and though I'd rather be kept up at night worrying about my patients and kids. So that's really hard. But I'll talk specifically about one of the gray areas in law that has been a challenge to us, which is that when you're using innovative models of care like peer support, which is actually a very well-known, super evidence-based workforce within healthcare delivery, but it's early in the broad use across all of mental health. It's mostly been used in substance use disorder. Then there aren't quite the same number of regulations in place, and so it's very much a gray area. So when we first started this, we started to get some legal advice about how we had to build our company. Do we need to build a full healthcare company, which is onerous and complicated and expensive and has its own risks that we're not complying in the right way, even though we're trying to? Or this is a non-clinical service, it's actually deemed non-clinical, so can we do our best to make sure that the services we provide are safe and private, but we don't have to follow all these very complicated laws? And we went to several different lawyers, and we got several different answers. Some people said, absolutely, you need to do this or you're going to be in trouble. And others said, no, you don't, you'll be fine. And then we have our other stakeholders who are the payers, who get nervous when we're not following the highest level of structural components to deliver what they deem as healthcare, so to be part of their team. And so these gray areas are really hard, and we have to decide what's the risk we want to be able to take, and still be able to do the right thing for our kiddos. The other thing I'll just say out loud is that we are a small company, and we want to put all of our money into developing solutions for kids, for young adults and adolescents that we take care of. And legal advice is really expensive, and we love our lawyers and think that they should be appropriately supported. But the fact that these rules and laws are so complex across so many different states just means it's really hard to build innovative solutions.
Kim, I won't take offense to what you said about lawyers. I've heard a lot of worse lawyer jokes. But I think, the takeaway from what you said is really, as an operator, wrestling with all these multi-state kind of patchwork of requirements, particularly around like confidentiality and informed consent. How do you operationalize that and streamline it into like a workflow that's actually workable for clinicians? And so I wonder if we could talk a little bit about some of the ethical dilemmas for providers that poses, particularly, for example, thinking about, notification and consent issues, and what to do when you're in a state where, it doesn't necessarily require you to notify a parent or guardian that a youth is in treatment, but it may permit you to do so, and when that's appropriate and not, and the legal risk.
Oof. So first I'll say, the way that I really anchor myself in making these decisions is, in medical school we learn this 4x4 table that talks about things that are ethical versus legal. And so I want to be in the place where what we're doing is ethical and legal, but I know there are things that I want to do for young people that are ethical but not currently legal. And so that's where it's the hard decision making. So we try to be in a place where we are doing the right thing and we can support what we're doing, and we take a little bit of risk, but that risk is around the legal and compliance things, not around patient care, patient safety, patient well-being. So that's how I'm grounded. The second thing I'll talk about is specifically around parental notification. So as a pediatrician, I work with families from the very earliest part of their life. And as I said before, I know that kids, young people, are almost always better when the family is involved. And so as a pediatrician, I start seeing adolescents alone when they're teenagers, and I kick the parents out of the room. And if something comes up that's very hard, that I actually don't have to notify the parent, the young person has a sexually transmitted disease or they are pregnant, I always try to figure out if it's safe to bring a family member or caregiver in, because it's the better care for the young person if they have support, they have a supportive parent in their life or caregiver. There are times when that is not safe for young people. And so that's the fine line of how we think what's ethical and what's safe for a young person. There are many families where certain things that happen to young people just aren't safe to bring to the family. So in our peer support practice, what we do is mostly support young people around issues that aren't quite that concerning, and we don't always have to get family members involved. But there are times when we sit down and we can say, look, here are the things that might happen if you have a supportive caregiver in your life who know about what's going on with you, and we can slowly and gradually figure out if that's the right thing for the young person. And again, it's like the ethical, legal thing. But when it's mandatory reporting, we mandatory report.
I think I'll add just from the in-house legal perspective, and I feel like this whole side of the stage, that conversation that y'all just had is a question I get every day. It's how do we do this? How do we operationalize? And so I think what I would say is more just from the perspective of someone who is an in-house legal advisor, and just have an open door policy with your legal team. There are so many issues and so many questions, and I mean, I can read laws and I do this every day. That's how I make, my living, but still I have to go to outside counsel and be like, hey, you are the subject matter expert, please help me. And so I think, again, it's just having that open door and communicating with your legal counsel. And if you don't have in-house legal counsel, really push to have some trusted outside legal counsel that can help. Because it's always better for you, if you're in operations, to raise those questions early, get ahead of it. Yes, it might be difficult. Yes, legal might tell you no, but that's what I always try to say. No, but let's find a solution instead. And so you might not be able to do it the way you want to, but in the end, it's just going to save you time, save you money, and save you a lot of heartache. And so I really do just like encourage everyone to have like a really close relationship with your legal team.
I'll add to that. Yes, so we're outside. We're not in the business. I like to think of what we do as being your ally and trying to get you to that compliant place, to a model that works so that you don't have to call us all the time. But we also are regularly asked to counsel clients on, okay, what is the risk if I don't make this disclosure, or if what is the harm that is going to be done? What potential remedy or what injunctions can be sought against me, or what's my license at stake? And so, kind of to build on what you were saying, the risk counseling is a big. I mean, I know in the clinical sense that's what you all are actually doing, but from a legal perspective, understanding of what is the ultimate patient outcome and what is the risk, the legal risk that's presented by the options that you have available to you. And two other things from like a malpractice perspective, if we're thinking of that, unhappy patients tend to bring malpractice actions. And so, and we know this, but that if you're doing the thing that is right for your patient and you know what the law is and you're doing something that is mostly compliant with that law, you are likely going to reduce your risk of those types of issues coming to you. And to offer a slight bright light at the end of the tunnel from a legal perspective, a lot is changing on our national and many state levels in terms of what new policy is going to be, a new administration and the like. There has been some recent legal precedent that has challenged kind of a lot of our existing regulatory scheme and the ability for regulators to issue regulations or guidance on those regulations. And while those are my bread and butter and I love them very dearly, it actually presents a lot of opportunities for folks to, maybe take a slightly less conservative interpretation of the law because there's slightly less deference to administrative guidance and agency decision. Now, I'm not saying that that's globally true in all circumstances and that it's without risk, but that is something that we're talking to clients about more recently, is kind of some of the changes on a national level and how that actually could allow more flexibility for operators.
Well, we've gone deep on the legal, and so we're getting close on time, and I want to pivot a bit to probably what you all care a little bit more about, which is revenue generation and reimbursement. And so can you just give us your thoughts kind of on challenges for this population on finding or workable revenue model and getting reimbursement actually for your services?
Okay, I'll start. So I feel like my add to this is fairly limited, but Spring Health, we do have a friendly PC model, and through that we are able to, if you're not familiar with Spring Health, how we started in this space was as an employee assistance program, like adding that EAP replacement for employers. And so, of course, when you are working with employers, you start focusing on their employees, but I know we have some folks in this room who are benefits managers at companies, and they're like, well, if we're caring about our employees, we're caring about their dependents. And so one of the ways you can generate revenue is through like just a per employee per month charge to an employer or to a customer. And so that is one way you can do it. Another, of course, is fee for service, but again, like what we talked about earlier, who's actually paying for that? And so it is difficult. So, Kim, Claire?
Yeah, I can. I've already alluded to how hard it is to get reimbursement for more innovative models, the kind of bite snack meal. So can you include chat and small bits of contact over time with a more traditional kind of hour-long video-based service? And so, as a new company, it's hard to get folks to reimburse more innovative models. What we hope is that over time, we can really build the evidence that what we're doing is so effective and so cost effective that we can evolve the payment mechanisms. But in the short run, we can't build the things that people want if we can't get them paid for. So that's just a perennial problem with innovating in healthcare with pretty fixed reimbursement methods. But the other thing I'll talk about briefly is Medicaid. So we deeply believe in taking care of people who are more vulnerable, and peer support's an incredible entry point for people who may not trust or feel comfortable with some of the more traditional ways of getting mental health support. And we can grow a workforce that makes people be seen by people like them. So we have been able to recruit and hire folks who are more than 50% are identify as Black or brown and or LGBTQ+. And this is fulfilling a need that just does not exist in the current therapy or psychiatry world right now. And so we're so grateful for that. I mean, the kind of feedback that we get from our clients every day makes me want to cry. And it's like, if we could, I promise you, we didn't write these things that they said. They come out of our mouth. And it's, someone who's 23 years old and says, I've been in mental health care services for a decade, and I've never felt seen or heard until I got into this service. So these are super important, and they're particularly important for the most vulnerable. So therefore, we're leaning into Medicaid. Now, Medicaid, while it provides incredible support for almost or more than now 50% of young people in our country, it's very difficult to deal with for a lot of reasons. It's state by state, as many, if not all of you know, and every state has really complex ways of dealing with every piece of the mental health system, and peer support particularly. There are different rates, so there's some states where we just can't deliver care because the rate's too low for us to make it possible. There are different regulations, and becoming a Medicaid provider in some states is easy, and in California it took me 2 weeks to fulfill the paper, and then I got a call 2 weeks after I had sent this in. Someone left me a message saying, you're a California Medicaid provider. You're not eligible to be a Medicaid provider in California. We're going to send you back your cashier's check for $750. Call me with the address, and after that, I'll shred your application. And this one, I literally had put blood, sweat, and tears into this application. And I called her on the phone, and we figured it out, and it's fine. But it shouldn't be this hard to get support for people. And then, some states, while they support telemedicine, you can't only be a telemedicine company, so you have to have brick and mortar. So it's just too complicated to bring the care to all the young people in our country with this very siloed, state-based regulatory system.
I'm not sure that I have a lot to add on the revenue generation perspective, but I will say that I think the thing I see clients struggling with is the challenge between, okay, if I structure myself in a way that's a traditional friendly PC model, though it'll be really friendly to payers, that is like the more traditional, even brick and mortar, because some state Medicaid programs require you to have brick and mortar, that has a whole host of costs associated, but potentially bigger upside because you can more easily get in network with those providers and start running your care and then add on the employee-sponsored care, for example, versus if you want to do a non-clinical based kind of support method of just peer support, coaches, a lot of different options there, which may take you you may not be able to get all those in-network arrangements, but you may be able to build a reputation in your space for being an outstanding clinical provider, which might lend itself to launching that kind of later, more formal structure a little bit later on in your journey. So,
Great. Well, we have about 7 minutes left. I'm not seeing any questions on the thing, but if
because
anybody
we're that
has
good.
questions here, we can.
We're that good. We answered all the questions.
Answer them all. Exactly. Yeah, welcome.
Hi. Hi, I'm Georgia. I've recently joined Equip, which is a virtual eating disorder company. And one challenge that as I'm getting my feet wet, I've heard a lot about from our mentors, our peer mentors, and family mentors has to do with patients who are technically adults and come to us and do not want their parents or families to be involved in their care, although we see that that's indicative of a level of ambivalence often about their treatment, and their outcomes tend to be worse as a result. And so one of the things I'm curious about in terms of best practices is any thoughts that you have on creative ways of building more comfort and willingness to have more expansive consent for sharing, so that rather than saying your patient is still enrolled, we could say your patient is technically enrolled and your child is technically enrolled but has not attended the last 3 sessions and has lost 10 pounds, right? A way of having more accountability and firm support from folks outside of the care team. Thanks for your thoughts.
I don't know, you might have a better thought. I'm happy to, the challenge, I'll be honest, there's a legal challenge with that, right? You have a lot of, if you are an actual in-network HIPAA covered entity, which maybe you might not be, you have some restrictions on the ability to share really any information with an individual who's over 18 with somebody you're not authorized to share that information with unless certain, exceptions apply. Putting that aside, state laws, even if you're not an actual enrolled HIPAA-covered entity billing third-party payers, there might be limitations from a state law perspective in sharing that information. I think the things that I've seen that work best is kind of encouragement to have the patient identify a person who you can share that information to. I know that's what you're trying to do, but that's from a legal. You run a little bit of a legal risk unless that person's really in like an emergency threatened situation of sharing that even basic information. Unfortunately, because there's not as many applicable exceptions from a legal perspective. But maybe you have some ideas from a clinical perspective.
Well, I'll just say this is very hard. And personally, as a parent of a now 14-year-old who has some struggles, I'm so excited for them to mature, and yet I'm dreading the day when they turn 18 if they still have the struggles they have. Because I've watched friends who have no control, no insight into what's going on with their young person's mental health. And we know that young people don't fully develop their brains till they're 25. So they're in this area where it's really just they're not ready to completely own their care, yet the law says they do. So not an easy answer. I'll say clinically, from years of talking to lots of patients and families about this, whether it's the parents who are unwilling to, not interested in vaccination, or young people who don't want to involve their parents. It's really about developing that clinical relationship with someone, and it takes time, and seeing them for who they are, and getting curious, and opening up, and figuring out why is it, what's the why behind that, what are the fears, and many, if not most times, I'm able to get my patients to do the thing that's right for them, and sometimes I can't. And sometimes we're not afforded that longitudinal care that allows that kind of relationship. So you brought up a very hard question.
I don't know what it says about me that I'm at a tech conference and I'm not using the high-tech Q&A option. So I'm a clinical psychologist by background, and kind of learning about the tech piece to this world. However, I've been here this whole time, and we have so much conversation around payers and businesses, and I haven't heard one thing about schools and their role in this, and how, and I'm sure it's just, if not maybe more complicated when you're working with a school district or a private school, but it's also one of the more front-facing ways you can access students who might not find it on their own or through their doctor. So are there things to consider from that perspective? And I'm also just curious your thoughts on why schools haven't been more part of the conversation.
Well, I can start with that. This was one of the questions that we had and wanted to talk to is, it's one of the ways that you meet kids where they are. And it hasn't happened for a lot of reasons. One is that, teachers work so hard, and school margins are so thin in many places that it's just hard to add another thing. There are some really exciting and innovative models in school-based care. In California, where I'm from, I'm a little more familiar with what's happening, and California just passed a law that says that health plans have to reimburse care that's delivered in school settings, which is super exciting. And there are very specific regulations around that, how that has to happen, but it just allows for things where the kid is able to do the job that they're supposed to do right now, which is be in school and learn, and the parent can stay at their own job. And it's particularly important for vulnerable families who, getting a parent out of an hourly paid job for a day is a massive burden on their family, and the kinds of transportations they need to get into healthcare providers is really tricky. So I love school-based care. There are some really exciting models that have been floating around here, at least 3 companies, one of whom has a representative in the room, who are building models for both physical but mostly mental health care in schools across our country. And I would look deeply into those companies because they're doing really important work, and I want to support everything we can do to support kids getting care in school.
Yeah, I agree. I think, a lot of what we talked about today is a lot of the reason that we haven't had that conversation as much here, just because of funding. Who's going to pay for it? The schools are so limited, especially public schools, on the funding that they have, and so how are they going to pay for this? And then, companies, it is what it is. It's revenue, and so are they interested in going into those spaces that might not be able to have that same level of funding. But then you also have those other issues that we talked about, consent, all of that good stuff. And so how do you work that out in a school space? And so I think those are challenges. But like Kim said, there are definitely some incredible solutions that are continuing to do these partnerships with different school systems. And so it is something that I am very interested in as well. But there are challenges that just have to be overcome.
Well, we're at time. Thank you so much for being here and for the discussion, and great job, and talk to you later.
Thank you all.